Our keynote speaker is Lynne Maher, Professor Lynne Maher, who's Professor of Nursing at the University of Auckland, Director of Innovation at Awatea in Auckland. Also has an adjunct position at the University of Tasmania. Has been a practicing clinician as a nurse for many years, but more recently has really developed an international reputation for her work in systems and systems improvement and doing what nursing does best, which is caring and actually being consumer and patient focused, which, if anything, typifies the way forward for dental health services Victoria. Not that you're not at the moment, but how do we make it more so and engage both with our staff and our consumers to make it truly consumer-centric. These are the challenges. They're not easy. If it was really easy, we would have done it already. Please welcome Lynne Maher.
Good morning, everybody. This is an interactive session. Okay, I'm very, very pleased to share my learning, but also to learn with you throughout the day. And I'm going to talk more about meaningful engagement in everything that we do. But first of all, I do want to recognise that I'm English, but I am living in New Zealand, and I bring greetings from our kaumātua, who is our chief, our iwi chief of the hospital system I work with. And we, as many of you know, we say kia ora as our greeting, and it means be well or go well. It's often used at the beginning of a sentence and at the end. So, being well and going well is very important for today. I absolutely love this Maori proverb. What's the most important thing in the world? It's the people, it's the people, it's the people. And most of us who come into health and care have a concern and a passion for people, be it the staff or the consumers that we're working with. And in every walk of life, there's kinds of engagement. Some of that engagement is transactional, and some of that might be needed to be transactional. It's thought to be, short and sharp, and while it might be pleasant enough, it doesn't feel very meaningful. It doesn't give the opportunity for a deeper understanding for patients about what just happened, why did it just happen, and what do I need to do next. And for staff, if there's a high level of transactional engagement, it often makes them feel not very motivated about really engaging deeply in the work that they're doing. It feels all very superficial. One of the most important things is it's often felt to be without care or meaning. It doesn't make me feel that I'm an important person in any situation, be it a patient situation, a family situation, or a staff situation. Now, on the other hand, meaningful engagement makes a massive difference to people. It provides that opportunity to be part of a conversation. It provides that opportunity to share my expertise with your expertise, and that is whether I'm delivering care or receiving care. I love this quote from Maya Angelou from America. People may not remember exactly what you did, they might not remember exactly what you said, but they'll always remember how you made them feel. And that's an important message for us in health and care. There's also quite a significant amount of research that demonstrates a correlation between that relational competency that we have, if we can, really relate with people so that they remember how we made them feel. And it links to quality and safety and also patient outcomes. Now, I'm going to talk a little bit about co-design as one method of meaningful engagement. And one of the notions around co-design is that it means people working together in partnership. And that includes those who are delivering care and our partners, if they're not in the direct delivery function, and those receiving care. Sometimes Staff think it's only about patients and families, but it's not. It's about us all together. And again, there's a significant amount of learning to say that staff who are highly engaged interact with patients much better than staff who have that transactional feeling. And also, the experiences of staff directly impact on the experiences of patients in our care. If we do nothing else but engage with staff well and make them feel highly competent, highly confident, and highly valued, that has a direct impact on our patients. So it absolutely is co-design, and I'm going to mention more about that later. It is important to remember that it's a dual way of engaging for those delivering care and those receiving care. We often get very concerned about variation in practice, and rightly so at times. And again, there's a lot of learning coming out to say that variance in patient experience significantly is influenced by staff work experiences. So again, it reinforces that we need to really focus on both staff and consumers. I mentioned co-design earlier, and when I'm talking about co-design, I use a model, and this is a model that I use and share with others, particularly around improving and identifying challenges and opportunities so that we can work together to design new ways of working, new models of care, and hopefully adding new value to our health and care system. Now, you will see there's a point where we have a project startup or an initiative startup, but the very next really important point is around engaging. And we engage to then be able to capture experiences, to look at the data that we learn through those experiences, to theme them up, to understand what insights and ideas that brings in our understand phase. And then from then we can move on to understand how we can improve those experiences of both delivering care and receiving care. And of course, there's measurement throughout in all contexts. But I'm going to focus on engagement now. Now, this is an old cartoon, and I know this doesn't apply to any of you. None of you have seen this or practiced this. It's an old cartoon of a number of clinicians leaning over a patient's bed saying, "When we want your opinion, we'll give it to you." Has anybody ever seen this happening in any walk of life or in healthcare? A few of you. Now, sadly, this is still happening in healthcare. We know from discussing with patients and their families that they feel like this. This is not meaningful engagement. And what happens to those patients and families is they're bemused and they say, "Well, I just don't know what happened. I don't know what I'm supposed to do next. And I have this leaflet, but I don't quite understand it." And it's a missed opportunity for that meaningful engagement that's going to make a difference to health outcomes. I wonder if any of you have ever been in this situation with the advent of social media and lots of places that we can go and find out more about our conditions. We often hear stories of where patients come in with reams of information that they've downloaded from Google and say, "Doctor or nurse, I'm afraid I have to disagree with what you're saying." And often the healthcare professions are exasperated by this, but I've got that little gift box in the corner. For me, it's a gift. If people are passionate enough to spend time downloading material about their condition, it tells me two things. It tells me we are not providing enough of that material to satisfy their needs, and actually they are passionate to do that. So it's a win-win situation, and we can work together to provide the information that they need. People worry when we're working with patients that actually lots of things matter to them that we cannot possibly afford to provide. And that's a worry that none of us should have, because actually there's a lot of evidence to say it's not so. Patients and family members know very much about how constrained our finances are, and that health and care is not a bottomless pit, but that we need to use that funding very carefully. But you know, what they say matters to them most is being treated as a person, not a number or a healthcare condition. Feeling heard, feeling listened to, feeling informed, and being given options that they can discuss about their care. Being involved in that care and being able to ask questions. Now, do we think that's unreasonable? Or do we really want that as well? I think any one of us who go through health and care systems would want that. But it's not only in health and care systems, it's every part of our lives. This is a photograph of a blackboard outside a cafe in Auckland. You know, somebody walks up in a slightly grumpy fashion and goes, "Coffee?" Well, you know, that'll be $5 for you, sir or madam. "A coffee, please." Oh, I like that a little bit better, so that's $4. "Good morning, a coffee, please." That makes all the difference. And so we've got to think about how we interact in every aspect. And it is verbally, and it is with a smile or, you know, a facial expression and your body language. This is not something that only patients want. This is something that we all want. Engagement is really, really important, as I said, in co-design, and actually the concept around engagement and understanding experience is important and adds to any of our current data sets of when we're starting improvement or change initiatives. Typically, I challenge healthcare people all the time, and I'm one of them, so I challenge myself to say, you know, are we really rigorous in our process to identify a problem or a challenge? The image here is of Albert Einstein, who's one of my favorite scholars, and I love what he says because it makes me think differently. If I had 1 hour to save the world, I'd spend 59 minutes defining the problem and 1 minute finding the solution. And you know what he's saying is really understand the problem before we leap to solution, because the solution probably won't work properly if we don't define the problem. Now, my challenge to people is that we're really, really good at data and health and care. We're a scientific community and we understand it. However, when we're working on looking at current processes in order to improve them, we focus on what I call organizational data. You know, did not attend, safety data, you know, readmissions, all those sorts of things. And actually, we don't focus enough on experience. We might use surveys and complaints and compliments or other feedback as a proxy of experience, but it's not enough. We really need to delve more deeply. And when I talk about experience, I'm talking about listening to those words that depict how I feel at every point in the journey. And that might be from the moment I walk in, what I smell, what I see on the floor, how I see people smiling to me, smiling or not to me, with me, and then to every clinical interaction, and recognizing those words are really important. Now, this is part of what we call lived experience, and understanding lived experience, I think, is, and so does Marie Ennis O'Connor, think is really equal to every other form of knowledge and data set that we have. And this is often an additional data set that we can bring to the party so that we increase our rigor. Now, when we're engaging people, there is no one single method that works for everybody. There's lots of different components to the you know, communities that we work with. And so, for example, in New Zealand, we, in my organisation's community, we have a lot of Maori people, and we engage with them very specifically. We engage with their kaumātua, their leaders. We engage in their marae, their meeting houses, and we engage using their cultural beliefs because that's important. With school children, we would typically engage with them in school with permissions because that's where they feel safe. And this is an image of working with people with rheumatic fever in schools. With older people, they really like to talk over tea and coffee and a scone or something like that. But equally, you know, has anybody got teenage children? Have you ever tried having conversations with them when they have their smartphones? So I've tried to engage with many teenage people in our community, and particularly from the Pacific and Maori community to talk to them about mental health challenges. And I failed when I started because, you know, they'd invited, we met in a convenient place for them, we had pizza, I was talking to them, I thought they were going to talk to me, and they're on their devices. And I'm looking, and I kept asking questions, which they knew I would do. And then I paused and I said, I'm really sorry. I thought you understood that I wanted to, you know, I'd come to ask you some questions, and I really value what you have to say. And I don't feel that you're chatting to me. And they all burst out laughing. And they said, we are. And I was confused. And they said, look at your phone. Well, so my phone was switched off because in my age, that's a respectful thing to do. But what they had done is found my text number and my Twitter handle, and they'd been communicating with me in that way. Now, it was actually to teach me a little bit of a lesson, because after they'd all had a good laugh, they broke the ice and they did talk to me verbally, but some of them still did use text and other social media. But actually, that was quite handy because they'd written down everything and I didn't need to transcribe anything at all. So, you know, we've got to think about the communities we want to engage. And that goes for, you know, patients or consumer groups, but staff as well. The most important thing is not only to tell people or show people, but to involve them. We don't want people to think that they're frozen out like this Alaskan frog. We want them to feel warm and able and to engage with us. So I'm just going to do a very, very short exercise with you to show the difference between engagement when we use surveys and I'm going to give you a quick survey. This is a very basic Likert survey where A represents, so I want you to focus on a meal or a snack you've had recently in a cafe or restaurant. A is really, really great. That meal or snack was absolutely fabulous. B is, oh yeah, that was quite good. C is, that was okay. D is, not so good. And E, really, really poor. Have you all got a letter in your mind? Yeah? Okay. So those who chose A, really, really good or really, really poor, if you could stand up if you're able to stand, please. Look around. We have a few people who've had experiences really, really good or really poor. Lovely. Could you sit down? Thank you. Those who chose, yeah, pretty good or not so good, would you stand up, please? Oh, we have quite a few more people around. Lovely. Thank you very much. And those who chose C, okay? Any okays? Yeah, the okays are either bored by the survey or can't make your mind up. I apologize for being rude. I'm judging you on me. Out of interest, I look at lots of surveys, but I do get bored and go down the C, the middle route. So now, that's really interesting. Keep that in your mind because what you've just created is what is a normal distribution curve, a bell-shaped curve that we normally get from this kind of survey data. So what does that tell us? What can you do with that? Actually, what it does give us is some insight. It gives us more insight if people put verbatim comments underneath, but it doesn't give us enough to act upon. Now, what I'd like you to do on your tables is one person volunteer to share their story of that meal or snack in a cafe or restaurant to another person in twos or threes, and I'm going to give you 2 minutes to do that. One person share the story and the other 2 or 3 listen. And listen out for emotion words. Go. Please, can I have your attention back? If you can see my hand, put your hand up and stop talking. Lovely, thank you so much. The raising hand and asking people to stop talking is a really fabulous technique that teachers use when they have unruly school children. It's a good facilitator trick. But actually, it was fascinating being up here listening to the noise grow and some laughter grow about that. Would anybody say that in your experience of identifying a letter on the survey and having was less engaging than the conversation that you've just had? Would anybody say the survey was less engaging than the conversation? The survey was less engaging, yeah. Does anybody worry about me saying, I think you can have many 2-minute conversations with each other and patients during the day? Oh, you're quite... Sometimes we're a little bit concerned because we're so busy, aren't we? We're really busy. But one of the things I want to challenge you in is to say, actually, and I'm not saying surveys are bad. Surveys are really good. They're really helpful. But they don't give us enough. Having a 2-minute conversation can give you a wealth of information. Did anybody hear in that conversation anything that was not only about the food? Did anybody talk about the environment, who they went with, the waiting staff, the fun? Often what we hear in these conversations is actually sometimes there's not very much about the food at all. It's more about who I went with, what the weather was like. I was sitting and I'd got this glorious view, or, you know, sometimes it was about the food. Sometimes it was saying that the food was terrible, but actually because I was with people I love, the experience was wonderful. You get all sorts of nuances that help you understand what A, B, C, D, E, or E mean. That's meaningful engagement. And actually the level of interaction, you know, and the laughter that was going on, I perceived that felt pretty good. I could see people leaning in, I could see people laughing, I could see people listening. And, you know, those who were sharing the story hopefully felt listened to. Those who were listened felt that they were engaging. That's meaningful engagement for staff and for patients. And, you know, please, when you go back to your work, please practice this. Please practice it all the time. You know, as I said, it's really important to have survey data. It helps us pinpoint some areas, but it very rarely can give us enough information from which to act upon. These short, meaningful conversations absolutely can. Sometimes you do need a longer conversation with somebody if you're trying to understand the whole of their journey in delivering care or experiencing care, but not very many of those. These short conversations can give us a wealth of information. I told you I loved Albert Einstein, so he always appears with me. And, you know, one of the things I remember from my health and care practice is that, you know, it is insanity doing the same thing over and over again and expecting different results. And we have a really good opportunity to be the forefront of new results. And, you know, sometimes in health and care, the way our systems have been set up are just the way our systems have been set up. And we're constantly going around and around doing the same thing. When really what we want to do is go upstream and find out why people are falling in the river. I'm going to give you a short example. In my health and care system, we've been focusing on people who have frequent readmissions. And actually, you know, we had a lady called Agnes who had 10 readmissions in a year. Can you imagine the distress that caused her and her family? Can you imagine the amount of work, time and effort that cost for her to come through our healthcare system? But we were doing exactly the same thing over and over again. We thought her challenge was with medications, but she could recite her medications verbatim, and she felt confident about doing that. We went home with Agnes to find out what she did when she went home. Now, we spent time with Agnes, it was about an hour, but actually we found out she was taking her medications incorrectly. We went down the river to find out why she was falling in. We were able to help her take her medications correctly. She knew how to take them, but she'd mixed it up with the history given by her mother of putting all her medications into a jar together. She just randomly picked them out, even though what she said she was doing was entirely different. That time was absolutely not wasted. It was well spent. 10 admissions a year for the same thing, coming in and going out on the same medications. 2 years later, following that, no readmissions. This can make a real difference. Agnes was getting sick every time she came in. Agnes has not been sick for 2 years. She's happy, she's healthy. That intervention has really made a difference to her health outcomes. So, as you go forward, please think about meaningful engagement. Please think about short conversations that you can have that give you an opportunity for greater understanding. And please remember, every interaction makes people feel differently. And we want people to feel happy, fulfilled, confident in delivering health and care services and receiving health and care services. Please work together to make the best health services we can, because we need to deliver them for the people we love now and in the future. Thank you very much for listening.
Stay up. You're not getting away that quickly. Sorry. Let me present this to you, though, as a gift from Dental Health Service Victoria as part of that.
Thank you.
Please thank Lynne Maher again. Thank you.
Thank you.
If you've got any questions you want to ask or any points you want to put, just raise your hand and we'll bring a microphone. And the person bringing the microphone to you, if you could just wave your hand at me to make sure that I know you've got a microphone for somebody wanting to ask a question. Meaningful engagement. So there's one part of meaningful engagement, which is what you talked about with Agnes, which is getting her narrative, getting the real story behind there. But the other, let's just go to co-design, which is the place that a lot of people in this room are at in a new model of care. Meaningful engagement could imply that I'm actually going to listen to what you do say and act on it. Yeah. It doesn't actually mean that, does it?
No.
So that's a con.
So no. Meaningful. I would argue. I would say meaningful engagement is not just listening to people, and then we going away interpreting what they've been saying and act upon that. I don't see that as meaningful engagement, particularly in the context of co-design. Meaningful engagement means we're not only listening, but we're working actively in partnership with people all the way along. So it's not just meaningful engagement at one part of the process, it's the whole of the co-design process, from really understanding what the problem, challenge, or opportunity is, to designing and delivering the new service or process or widget or whatever we're looking at.
You've got to be careful about the expectations you set, I assume.
Tell me more about what you mean about that.
I'm designing sound like the Prime Minister. I'm designing a new dental health service model of care in Richmond, Victoria, and I'm listening to your views about what happened here. Let's have a conversation about that rather than just doing a survey. And you're going to tell me about that. you could be led to believe that what you say will actually end up as part of the design. That's really what I'm getting at.
And actually, I think what you say comes into the mix of part of the design, but we're not only talking to one person. And so what we're doing is talking to people, listening to people, involving people, so that it is an iteration. It's not a one-off event. I'm just sharing with you that I think we need 4 red chairs instead of black chairs, and that's it. But it's a collection of people, and it gets included in the design. Now, there's always a prioritization, because there's always rules and regulations about everything. And as long as people have been listened to and they can see what the themes are coming out from the whole and how decisions are made, then that's comforting. So if I'm a staff member, everything I say is not going to necessarily be implemented, but it's about a true partnership in the process. Does that make sense?
Yep. Yeah. So here in Victoria, about a month ago, I interviewed Michael West from the University of Lancaster, who talks and has researched one of the points that you made, which is to some extent counterintuitive, but is that if you have unhappy staff and an unhappy workplace, you have an inefficient workplace, you have a dangerous workplace, and it's certainly not consumer focused. Just take me through your thinking in that, because it sounds self-indulgent, happy staff, happy patients.
If you've ever turned up at work one day and you're not feeling very happy, and you walk on and everybody around you or somebody doesn't acknowledge you when you come in, and they say, oh yeah, just go up to your normal end and do your normal work. Actually, I don't feel very engaged. And then my mood has changed, even if I came in a happy mood. Even with the best will in the world, I'm feeling a bit upset because I'm thinking, well, what have I done to that person? Why aren't I, why aren't I being treated differently? Now, with the best will in the world, the likelihood is I'm not going to be as caring as I could be with the patients. This is not saying staff or patients in that situation are bad people. It's just how we're made to feel. And it's hard to lift yourself up from that. West has done a lot of work with people, and really being able to demonstrate the difference that interactions make. You may say it sounds self-indulgent, but it's about behaviour. It's about the psychology of how people make you feel. Sometimes you can pull yourself out, but sometimes you can't.
So he talks about meaningful engagement between staff coming first, and that's about showing you care, but showing you care in a meaningful way.
Yeah. And I think I actually believe that's right. And when I do co-design, I'm working with people, I typically work with the staff first so that they know they are important. And then I work with the consumers. And the other thing that they know is they know exactly what we're going to ask. Because staff often, when we're talking about co-design and engaging with consumers, they think, oh, we're just going to ask them everything that they don't like. And that's not true. We're looking to see what works well, what people love about what we do, so that we can cherish that. And we need to understand what's not working so well and the ideas for improvement.
Can I have a microphone at this table here, and Pam?
Thanks, Lynne. That was is it on?
Yeah, you're on.
Okay, yeah. Sorry. Thanks, Lynne. It was a great conversation, and thanks for your conversation last night as well. One thing you've been talking about is the individual co-design and their treatment. One of the challenges I have is looking at how do you co-design when you're looking about organisational structure, governance, strategic plan, and making it meaningful. When you're looking at, say, structure, there's a lot of background governance, history that consumers or individuals and patients may not be aware of. So I personally have that difficulty in making that transitional concept.
Yeah. Yes, thank you. So a lot of what I've been talking about is co-designing with people who've got lived experience of the particular area we want to explore. However, absolutely, co-design can occur at every level of the organisation. At the level of governance, you're right, people who have not been staff don't necessarily understand all the background to that. Actually, some of the staff don't understand the background to what's happened. And there's an important orientation period. But what we've got to remember with people who we call consumers or patients is they don't only come because they have or not had lived experience and they come to share that, but they come as a different, as individuals. They are, mums who are managing 3-4 children and looking after older parents at home. They're fabulous project managers. They're people who've come from industry. They're people who've been in governance in other roles. And, we're making or sometimes we make an assumption that people can't work with us at that governance level. And actually I found that they can if we take time to orientate them. What they do is bring incredible new insights that typically we don't think about as staff because we're slightly closed. So they bring insights from their industry.
Yes.
Hello, is it on?
Yep, you're
Yes.
on. It'd be a good idea just to introduce yourself so the speaker knows who Lynne knows.
Hi, Lynne. I'm Shane Maguire, formerly employed by Dental Health Services Victoria. Thank you for an inspiring talk. The Agnes story was beautiful. I wonder, however, do you have aggregated data around meaningful engagement, and if so, what does that look like?
Yeah. So that's a really good question, and a question that I get asked quite often. We have to start somewhere with individuals, and in the piece of work I was describing about recurrent admissions, I just gave you the story of Agnes. We had worked with about 150 people who were very high users in terms of readmissions, and they've all had the same outputs, the same differences. Not everybody has not come in, but the level of readmissions has gone down massively. We've been working with people who are falling regularly on one ward and then translated that learning to other wards. So, it's about starting small, but then recognizing that the spread of these methods can then show system level improvement. So it is about starting with one. You can't aggregate up necessarily so quickly, so it can be quite time consuming, but I think it's worth it.
So the implication in that question, though, is that you could start planning based on anecdote. So a survey at least gives you objective information.
Yeah. One
conversation could tell you something and you go off on that and it's just an outlier and you don't realize it's an outlier. Yeah. So it requires a sort of a narrative analysis, doesn't it not?
Yeah. So I would never go on one anecdote. There's a confidence level that you need, and it is about aggregating data together. So survey data, organisational data, and experience data. Sometimes you might have 4 or 5 conversations, and you say, "Oh, this is really clear now."
It keeps on coming out, and it probably will if it's a significant issue.
Yes.
Yes.
Oh, hi. My name's Claire.
Claire.
Hi. I've worked in agencies before, and now I'm working and studying at the University of Melbourne. And one of the areas that I'm looking at is motivational interviewing and how that plays a role in our communications with clients and helping to build an atmosphere of compassion and acceptance and helping to move them towards their goals to make a behaviour change. And I guess what we're also talking about here today is everyone making a behaviour change. And I wonder if any of the work that you've done in the past has looked at the clinicians who are at the face of it all, and giving them the skills to be able to feel empowered within themselves to help clients make changes, and if you use motivational interviewing as a way of developing that.
Yeah, so yes and yes. So motivational interviewing is something that gets shared and talked with quite a lot of clinicians in the system that I work in.
But it is controversial. Some people are saying it doesn't actually work as well as the believers think.
It is controversial, and what we have found is it works particularly well where there's challenges that we have not been able to get to the bottom of. So smoking cessation, alcoholism, and a particular challenge which is relevant to a speaker later on, a particular challenge in our South Auckland area where children in socially deprived areas sometimes have a litre bottle of sugar-full Coke for their food for the day, and actually helping healthcare workers to use motivational interviewing and techniques with those families has actually unlocked the ability to change behaviours more so than other interventions that we've tried, and they've been trying them for
But if you're talking about a clinician
years.
intervention, I mean, I'm not putting it aside saying it's useless, but it's been shown that it's a barrier to clinicians. Think, oh, I've got to know motivational interviewing if I don't know it. And the QUIT campaign in Victoria has found that, in fact, it's reduced quit rates by people thinking they have to do motivational interviewing. And if you actually just do a brief intervention followed by support, you often get them as far down the line as you would by being obsessed with motivational interviewing.
I think part of the thing is the terminology. Clinicians don't often, especially doctor clinicians, don't relate well to the terminology. Actually, if you're teaching motivational interviewing and they can adapt that to some of their natural style without losing the concept, and we're not using that terminology, they feel much more comfortable about doing it. And I'd say exactly the same about the term co-design. I'm talking about it to you when I'm working a lot with clinicians. I don't say, hallelujah, we're doing co-design. I talk about how we can work together to really understand what's happening and do something about it that's going to stick.
Thank you for that question. Don't be, I am a believer in it. It's just that you've got to be tempered. Thank you very much, Lynne.
Thank you. Thank you.